Hi, I'm Dr. Sherman Silber, Infertility Center of St. Louis, here in St. Louis, Missouri. And we're going to do a Facebook Live discussion, and we're going to start out by talking with just one of our mini IVF patients, and you'll hear something about how we do this mini IVF and what the results are like. And I think it's fantastic, particularly for women who have reached, I won't ever say older women because I really get them angry when I say that. For women whose eggs have gotten old, how
advanced maternal age.
Yeah,
That's
advanced
what my OB said.
Right, yeah, advanced maternal age, right. And we're here to answer any other kind of questions that you want to write in anything that comes to mind, or you can ask Suzanne some questions as well. And of course, you can always get information on a website, which is www.infertile.com, and on any questions whatsoever. So, Suzanne, tell us about what happened with you.
Well, I had a little boy who was 4 years old when we got to the point where wanted another child, and again, getting older. I had my first one at 38, and
so you were pretty lucky there.
I was, at that point, my OB said, "Oh, you're advanced maternal age." At that, with that one, and then when I started trying again for the second one, just nothing happened, and I went through and he did the dye test on my tubes.
Make your tubes are okay.
That thing, and said I was fine, couldn't find anything wrong, and basically said that it's just my age.
Yeah.
That obviously we're born with what eggs we have, they decline and everything, and said rather than trying to take whatever drugs to maybe try, he's like, with that age, he's like, just start. He's like, just go. If you're gonna even do the IVF, mini IVF in this case, he's like, you're better off to just start it instead of waiting any longer. So that's what we did.
Well, he or she, I don't remember who you're.
Ravi Johar.
Oh, okay. So you got really great advice, because, I mean, so many women are told, well, let's wait a year or 2 years and see what happens before we go into anything radical and aggressive like IVF. Mm-hmm. But that your whole problem originally was your eggs are getting older.
Yep, and then when I came in and spoke with you, you had alluded to maybe because of that I should consider donor eggs. And I said no, that I adored my son that I already had, and I wanted another one just like him. And so we went ahead and went that route, and ended up with...
Not with donor eggs.
Not with donor eggs, but yes, with my own.
No on that.
Yeah, sorry, said no to the donor eggs, and yes, went with
confused,
my own egg. And we went through the whole process, and it was kind of tricky at the end, I guess we'll say.
Yeah, let's talk. So the mini IVF idea, and we started out with the worst, most difficult cases like yours. You had very, very few eggs left. Not only were they 42 or 43-year-old eggs, but you had very few left. And we specifically designed mini IVF for that situation. But gradually, we've been doing it on younger and younger patients gradually. And we're pretty excited. It seems to work at any age very, very, very well with minimal drugs. And our last publication 2 months ago showed a live baby rate per egg that was 5 times higher with mini, not just a little bit higher, 5 times higher that's per egg, with mini IVF than with conventional stimulation. So with conventional stimulation, you get a whole lot of eggs in younger women, but most of them aren't any good. But in, should I say older women?
Yes, that's it's okay. That's the way it is, yes.
Either way, we're not going to get many eggs, so we want to get the best quality eggs.
Right.
So, I don't know, maybe talk about what we did and what you did.
Well...
How long ago was this again?
My son actually is turning 8 tomorrow.
Oh my gosh.
Yes. So yeah, he's going to be 8 years old tomorrow.
2007 or 2008?
Yeah, he was born in August 10th, 2009.
Wow.
So we started the process in May.
Yeah.
And we went through and did the first round of retrievals and ended up with 2 viable embryos the first time. and your goal was to transfer 4.
Yeah.
So I did a second round, and we only got 1 that time.
Mm-hmm.
So correctly guessing that the eggs weren't going that well. So I got 3 out of it. And then the day that we were going to do the transfer, I remember I was sitting there, and you and Dr. Pineda came walking in and had this kind of glum look on your face. And that's when you came in with this.
Why don't we show that?
I don't know if anybody can see this or not. And what it is, these were the 3 embryos that I had. And I'll let you explain what happened.
Well, you can see that we only have 1 good quality embryo. It's a 8-cell, perfect-looking day 3 embryo. And these other ones really weren't good. I mean, this is a 3-cell, this is a 2-cell with unequal size. So we really only had 1. And in a 43-year-old woman, you'd rather have more than 1 embryo to increase your odds. And it's not because of her age, it's because of the age of the eggs that the embryos came from. So this is really all we had.
That was it. And so we went from, as I brought in a picture, we went from this to this. So this was him. This is his picture from last year. So yeah, I mean, it's kind of interesting to see.
Yeah,
he is,
it's so funny. You see them together.
Yeah.
The embryo and the 8-year-old. Yeah.
And he is a perfectly healthy boy. Has no issues whatsoever. Does great in school. Plays sports. So yeah, I got lucky, and he was a miracle baby out of all that.
It's exciting.
Yeah.
Well, you had tremendous guts and patience, because it was very difficult. I do recall very few eggs, and all we got was 1 good embryo, but hardly any eggs you had. But the idea of the mini IVF is at least you want that 1 egg that you get to be the best quality, so you'll have a good pregnancy rate. And we didn't know for sure, remember exactly what our statistics would be per egg at that time. But now we've actually analyzed thousands of cycles, and a paper a couple of months ago in Fertility and Sterility Journal, and it really is amazing. You have to look at it per age, and the curve certainly goes down per year. But at any age, the live baby rate per egg was 5 times greater with minimal to no stimulation per egg than with ovarian stimulation.
I will just say, because I had talked to a few people afterwards, the whole process was not very scary. You get to know the people here. You come in and you do blood draws on a regular basis. You do ultrasounds on a regular basis, and so you get to know the people here and everybody that's going through the same thing you are. So you kind of get to know it's a little community of people always doing this. But it's the first thing of doing a shot in my stomach, when I had to do that to myself the first time, I was scared to death. I will say that, and I was just kind of like, ah, and I did. And I was like, oh, that's it, So
well, you're not sticking something deep into your stomach or stabbing yourself.
Yeah.
I want to make sure.
No, yeah, it's just a little. It was just a little one. Now
it's the skin under your body.
The progesterone is
that's not comfortable.
The one afterwards, that one's not comfortable, but well worth it.
Yeah, but the actual IVF stimulation is pretty easy compared to, it's really minimum elevation of hormones compared to IVF, where you just have often 600 international units of gonadotropin, and you had 150 every other day instead of 600 per day, and you're relying mostly on Clomid. And when we've used huge doses in women with low numbers of eggs, we don't get any more eggs because it's limited by what your antral follicle count is and what your ovarian reserve is. So better to do minimal stimulation. Anybody have any questions yet?
Yes, you are getting some questions. Missy would like to know, I'm almost 43 and I had my tubes clamped 16 years ago. I have 3 children and have been diagnosed with adenomyosis. Would mini IVF work for me?
Well, so that's the question. She has a number of things going on. Her tubes have been tied. She has adenomyosis, which means endometriosis of the uterine muscle, and she's 43 years old. So mini IVF is the only thing that makes sense, and it would work. Now, I can't guarantee anything. We'd have to see her ultrasound and know what her antral follicle count is. But Suzanne's was very, very low. So, if we can just get a few eggs from stimulating her with mini IVF and possibly do several cycles, then that would be good enough, because it's a remarkably high pregnancy rate per egg. Now, the adenomyosis, we'll have to see how bad it looks on ultrasound, because it may need no attention at all. But if it's a really big, bad case of adenomyosis, causing painful periods, miserable periods, and in fact having to lie down and be in bed for the first few days of the period and taking pain relievers that are pretty strong, that kind of adenomyosis is pretty severe. We need to operate on it. But before we operate on it, I would want to get her eggs and her embryos and freeze them and hold them before she gets older, because the time-sensitive problem is the age of her eggs. We get the embryos, and then once we have that, if she has bad adenomyosis, which we don't know yet, then actually it's on our website. We're, I think, one of the few centers in America. We've actually learned it from an expert in Japan, Dr. Osada, and we do the Osada procedure, where we've had fantastic results with adenomyosis. So we're not afraid to operate on it. It's a big operation, but it really works, and there's almost an immediate improvement of the symptoms. But if she doesn't have bad symptoms, if she doesn't have what I'm describing, then the adenomyosis is not really important. It won't interfere with pregnancy.
Okay. Brittany says, I am 29 years old and have had tubal factor infertility and PCOS, 2 tubal pregnancies, 1 in each tube. We've been able to conceive with 50 milligrams of Clomid, but we're not committed to traditional IVF. She'd like to know if she's a good candidate for mini IVF.
Okay, so here's a woman that has both PCOS and she has tubal factor, both of those things. But the good news is she's only 29 years old, so this should be a relatively easy case. As I said, now we are finding that mini IVF is preferable at any age. 23 years old, 29 years old, 43 years old, it really will give us better quality eggs. And with PCOS, she's probably going to have a lot of eggs anyway. Now, this will be shocking, but when we've done mini IVF on PCOS patients that are in their 20s, we'll get as many as 15 or 20 eggs with hardly anything but a little Clomid. We're not trying to get a lot of eggs, and they don't have hyperstimulation syndrome because we trigger them with Lupron, and we just don't have any hyperstimulation risk syndrome at all anymore. It just doesn't occur. And so it's very, very comfortable and very safe, particularly for women that don't want to be overstimulated. Now, the one thing I'll say, when we do her ultrasound, we'll check and see if her tubes are dilated. We call that hydrosalpinx. She's not going to like the sound of this. But if her tubes are dilated, the smart thing to do is laparoscopically remove them, because there can be fluid dripping down into your uterus, and that can interfere with implantation of the embryo. But if we don't see a dilated tube on ultrasound, then that's not a big deal. I'm just pointing out, first thing we do is we'll get the embryos, get good quality embryos. I'm sure 1 little cycle of mini IVF is enough. And while we're doing that, we'll check carefully to see if her tubes are blocked, like you had done by your doctor, I think, a year before we saw you.
Right.
But we can check that and know, and if the tubes are not a problem, then we don't worry about it. The tubes, and she's had ectopics, but if we don't see dilated tubes, then we don't even worry about that, because we'll put the embryos in the uterus so she won't get an ectopic.
Okay, Jamie would like to know, does BMI matter as far as treatment from your center? And I'm not sure if she means a high BMI or a low BMI, but could you speak to both?
Okay, so what we're talking about is someone who's really super skinny, because sometimes they don't ovulate, don't have normal hormonal function, or could it be that she's very overweight? Well, I don't think anybody should be overweight. I mean, it's very, very tricky and very difficult situation. It's very, very hard to lose weight. But I would never recommend that someone stay overweight if they can work on losing weight. I mean, I want to make that clear. But our pregnancy rates are just fine with women who are overweight. So we don't want to put them under pressure. And particularly if we say, well, work on losing weight over the next year, lose 100 pounds or something, and then we'll do it next year. Well, if she's getting older, I don't know what her age is, but if she's getting older while we're waiting, then that's really bad. So we like to not let those eggs get older while we're waiting. I don't think it's crucial to be at normal weight, so it doesn't matter what your BMI is in terms of us having a successful result and doing mini IVF. But if someone is really high BMI, really high overweight, then for health reasons we'll recommend weight loss programs, but that won't interfere with working on her having IVF.
Okay. Katie would like to know, my husband had his vasectomy 15 years ago and he would like it reversed. Is there a big difference between 15 years or 1 year?
Well, that's very interesting because we reported the first microsurgical vasectomy reversal in 1975, and we were on the front page of the New York Times about this. It was revolutionary in October, I think it was October 15th of 1975. And so we've done somewhere over 10,000 vasectomy reversals. But there's a lot of confusion about vasectomy and vasectomy reversal. When we originally did that, we found that if the vasectomy was more than 10 years ago, it was only 50% successful. If it was less than 10 years ago, it was about 95% successful. None of that applies anymore if you're just putting the vas together, because vasectomy will normally cause a pressure buildup in the system with blowouts and perforations that you don't feel in the delicate ductwork closer to the testicle, we call the epididymis. So these epididymal blowouts will interfere with sperm passage, and so even if you do a perfect vasectomy reversal, vas-to-vas repair, they won't have a successful result. But so that's important to know, because I think usually the approach is just do a vas-to-vas vasovasostomy, and nowadays, because the vas is sealed so tightly when they do vasectomies, it doesn't matter if it's 1 year ago or 15 years ago, they're not going to have a successful result unless we go to the epididymis. So 90% of the time we go to the epididymis. It's much more difficult, but we have great results with it as long as we're willing to do that. But the classic approach that most urologists would use, vas-to-vas, I think would be poor results in the modern era, whether it's 1 year ago or whether it's 15 years ago. It's totally different than it was when we first reported results when vasectomies weren't sealed so tightly. I've recommended that doctors don't seal the vas tightly when they do a vasectomy, but they don't pay attention to that because it just doesn't feel right to a surgeon not to seal it tightly. So they feel they've improved the technique and they don't care about reversibility. But if you care about easy reversibility, you wouldn't seal it tight and you do the vasectomy in the old-fashioned way. If none of that is appealing to a patient, though, we can certainly retrieve sperm and do IVF and ICSI. We didn't care what your husband's sperm count was. It didn't matter whether it was good or bad because we inject the sperm into the egg.
Right.
And so as long as there's any sperm whatsoever, you don't need 50 million, you don't need 10 million, you don't need 5 million, you don't need 10,000. If you have 2 or 3 sperm, that's all you need.
Okay. Chelsea, who is coming in tomorrow with you, she'd like to know, what are your thoughts on the Denmark IVF? I will see you in the morning for my egg retrieval. I'm 27 and have had 2 failed retrievals. Her husband had a vasectomy reversal, but they're not having any luck getting pregnant naturally. They tried the frozen sperm that you took out and are not having any luck. They'll see you tomorrow for a MESA. So bottom line, what are your thoughts on Denmark IVF, and can you explain what that is?
Well, let me explain that. Yeah, the mini IVF is, I think, really the best protocol now for the reasons I explained. But there's 2 ways of accomplishing it. The way you did it was with Clomid, and the benefit of Clomid was that you get an equal and mild elevation of FSH and LH. Now, the FSH recruits the eggs, but it really doesn't contribute much to egg quality. The LH doesn't recruit any eggs, but it contributes to egg quality. And so what you want is a low increase in FSH for recruitment, so you don't get any toxic effect of too much FSH. But you want an equal recruitment, an equal elevation of LH, so that you get good egg quality. So that's one of the secrets of mini, and we added a little FSH every other day, a low dose, because as you begin to make follicles, the estrogen level goes up, and the FSH level goes down, therefore. So we give you a tiny dose of FSH to keep your FSH at that stable, very, very slightly elevated level. So that's what the traditional Clomid mini IVF does. You might get a little bit more punch from something we developed in Denmark, which we should call it the St. Louis mini IVF, but we're calling it the Denmark mini IVF because that's what we originally called it, because we worked it out in Denmark. So you can do the same thing by giving low-dose FSH every day, but also tiny microdose HCG every day, like or every other day, every third day. We can't give LH. That doesn't work, and we don't even have it available because it goes in and out of the system so quickly, and we don't even have it available in the United States. But if we did, it's not really any good because it doesn't last very long. But so we can accomplish the same thing with very tiny dose. By tiny dose, I don't mean 10,000 units or 5,000 units or 100 or 1,000 units. I mean 100 units every third day or at most every other day. So that way you do the same thing you do with the Clomid mini IVF, but it's with exogenous hormone. And I prefer Clomid usually, but occasionally you're better off with using, I prefer Clomid if there's a low number of eggs, usually. But occasionally, when you don't get anything with Clomid, then with the Denmark approach, you might get an egg or two. On women who are younger or who have a lot of eggs, then if they're willing to have more shots, the Denmark mini IVF is just great. And we'll usually get more eggs, but with very little FSH elevation than we do with Clomid. So, it's a toss-up, Denmark mini IVF or Clomid mini IVF. It's hard to tell ahead of time which is going to be better for the patient, except usually if there's someone like you, I would prefer our classic Clomid mini IVF. So it probably shouldn't be called Denmark, but that's what we started calling it when we started doing this years ago, and because we were actually working this out at a meeting in Copenhagen. And that's what we call it now. So I guess, I don't know, I guess I'll see you tomorrow. We'll talk about it further then.
Let's see. Brittany would like to know, how is the transfer different with mini IVF versus traditional IVF? And she means in terms of the process, injections, and timing.
Okay. Well, the embryo transfer, if you've been on Clomid, as you know, we prefer to do it 3 months later. Because we want the uterine lining to be as natural and normal as can be without any stimulation. And we'll often do that with Denmark mini IVF as well, because we introduced in America, we were the first people to introduce it in America, a method of embryo freezing that is really fantastic. And so it's vitrification. It's now widely practiced in the U.S. and all throughout the world. So we're willing to freeze the embryos. Now, these two embryos weren't very good to start with, and this was really the good one. But the good embryos really survive very, very well, and we're not afraid of that. So we like to freeze the embryos, and then, for Clomid at least, and wait 3 months before we do the embryo transfer. Now, the embryo transfer involves, I think it's better to have a perfectly timed cycle rather than a natural cycle. Many control studies have shown that if you have it perfectly timed with hormone replacement, the results are higher. But you have a choice. You can have those nasty progesterone injections that you had, and in America, most women prefer that to the alternative. And the alternative is progesterone suppositories vaginally. And if you're going to have the same success with that as progesterone shots, you have to do it 3 times a day. Once a day or even twice a day recommendations gives a lower pregnancy rate. That's why in America pregnancy rates are 15% higher than in Europe, because the majority of clinics in America use the shots. But if you don't want the shots, we can always give it to you vaginally, but we'll lower the pregnancy rate with that unless you're willing to do it 3 times a day. And then there's just no shots at all, so it's really easy on you shot-wise.
What is the process for a patient that has naturally low progesterone?
Well, I think that's usually a misdiagnosis, naturally low progesterone. As you know, or maybe you don't know, in the first 2 weeks of your cycle, normally, you're just making estrogen, and then after you ovulate, you may still make estrogen, but that's when you make progesterone, because your follicle turns into what's called a corpus luteum. And the first 2 weeks of your cycle is to prepare your uterine lining. That's proliferative, and the second 2 weeks we call secretory, which is to create vascularity in the uterine lining. So without progesterone, you can't implant, and the timing has to be absolutely perfect. In other words, there's a very narrow window after you start progesterone when the embryo can implant, and you've got to get it exactly right. So if a woman, however, has a low progesterone level in her luteal phase, that is generally because there's an ovulatory dysfunction and a problem in her earlier follicular or proliferative phase. So giving her progesterone isn't going to help any. What you have to do is support the whole process of follicular development. And I happen to, although the usual process is stimulate with hormones and do IUI, that's insemination, I go back a long way, and I don't think intrauterine insemination increases the pregnancy rate over timed intercourse. So you can just do ovarian stimulation with timed intercourse. It's just as good as IUI. IUI makes the patient and the doctor feel better because it sounds like it's a procedure, but it doesn't improve anything over timed intercourse. But I think that ovarian stimulation without IVF always runs the risk of dangerous multiple pregnancies. And many of those cycles are canceled. I think in the modern era, it's a atavistic approach. I think it's out of date. I think you go right to IVF, but since IVF can be such a pain in the neck and so expensive, I would prefer mini IVF. It's so much easier, but I would go earlier to mini IVF and not temporize with stimulation. So the diagnosis isn't really low progesterone. That's just a symptom of the fact that she doesn't have good follicular development.
Okay. Let's see, what else do we have? Can you carry a baby if you're in menopause?
Absolutely. That's a really good question. Can you carry a baby if you're in menopause? Absolutely. We've had successful pregnancies and healthy babies up to age 60, and it's reported as high as age 63. Now, those would be rare cases where the woman at age 60 is extraordinarily healthy, and there is either she's got a younger husband, or she's got this is for social reasons, or she's got a good extended family. But if that's the case, there's no problem at age 60 carrying a healthy baby. Age 55 is the usual upper limit, but I think age 60 works. Menopause is not a problem. We replace hormones, we get the uterus cycling normally, and these would normally be women that have donor eggs because they've run out of eggs. And pregnancy rate is only related to the age of the egg that the embryos arose from. So yes, you can get pregnant anytime after menopause.
Okay. What is the average cost of mini IVF per stimulation? And this sometimes depends on the patient, correct?
It really depends on the patient and if they're older and they need several cycles, then that can add up. The first cycle can be about, it's too expensive. It started out at $6,000 in 2003. We try to keep it as low as we can, but now it's up to $9,000. And then the second cycle, if she needs more cycles, is less expensive. and the embryo transfer is always included. So she could do multiple cycles of retrieving eggs if she needs to, and it's a lower cost for that. And then the embryo transfer, of course, is no cost because that was included in the first cycle that she did.
Okay. What are the chances of getting pregnant while doing IVF and having endometriosis? Or I guess what's that process?
Wait, say it again.
The chances of getting pregnant while doing IVF and having endometriosis.
Endometriosis absolutely does not interfere with pregnancy rate. That's an important thing to say, because there used to be a theory, which is totally wrong, that endometriosis created a, quote, hostile uterine environment. And so, but so many studies have shown that the pregnancy rate is no different with endometriosis than with no endometriosis. The only problem that endometriosis creates in a woman who's infertile is if it's in the ovary, it can create pressure that reduces the ovarian reserve and the number of follicles left in the ovarian cortex. But otherwise, buzzing these little endometriosis lesions in the pelvis on laparoscopy is a totally outdated treatment, and it doesn't do anything.
Okay. Marciela would like to know, in mini IVF, do you implant one embryo at a time?
Well, Suzanne, why don't you answer that one?
No, the goal was to do 4 at one time.
Only because she was 43.
Yeah.
Okay, we wouldn't do that in the younger woman.
Right.
Okay.
Because I was older. But yes, he wanted to do 4, and I ended up, so that's where this came into play, where I had 3. The 2 didn't work, and I just had the 1 good one, so it was just 1 transferred, and it worked.
So most women in America want us to transfer 2 embryos. We're willing to do it, but and most women want that. But if you want a single embryo, that's what we all prefer anyway, and we're happy to transfer only 1 embryo and have a singleton and 1 baby at a time. But it's up to them. The pregnancy rate certainly is twice as high, really, with 2 embryos as 1 embryo. It's just arithmetic. But the risk of twins then can be as high as 30%, and the risk of triplets is extraordinarily remote, but it could occur if one of those embryos becomes an identical twin and divides. But that's really a pretty rare event. So we'll transfer 1 or 2, whatever is their desire. We won't transfer more than 2 unless they're like 43 years old. It's a different story. We've never had a risk of multiple pregnancy in an older woman like that.
Okay. Denise would like to know if she can get pregnant after a tubal ligation with IVF.
Oh, yeah. So we have a choice. If someone's had a tubal ligation, we can do a reversal. We're really, really good at that. We reported the first microsurgical reversal in the United States in 1977, so it goes back a long way. And so we've done hundreds and hundreds of them, and that's just fine. But the other option is IVF, and that's just as good an option, and it's sort of the woman's individual emotional take on this, which way she'd rather go. Would she rather have a little surgery and be done with it and get pregnant with intercourse, or would she rather avoid any surgery and just go through the IVF procedure and have the hormone injections? IVF isn't such a terrible process nowadays with mini IVF. It's pretty easy to go through, I think.
It was, I'm a scaredy cat, I will just tell you that. I'm not one for the needles and everything. Like I said, kind of freaked me out at first. I've always been pretty healthy, so I never had to go through anything like that. So I was a little leery at first, but it was very easy. Even with the progesterone shots, I ended up giving those to myself.
Oh, that's pretty good.
I worked with somebody who gave them to me during the week, and then on the weekends I gave them to myself.
That's fantastic. Yeah,
so yes, it's very doable, I will tell you that.
Yeah.
Can you talk a little bit about the emotional aspects of going through IVF?
Sure. It's the waiting and the wondering, of course, because you go through the first course, and as you're going through the testing, they're seeing, how many follicles do you have, how many eggs are out there, and every time you'd go in for an ultrasound, I'd be looking at the screen like this, trying to count myself and see if I could see anything. And every time I'm like, do I have enough? Are you getting anything? How's it going? And they were very nice. They talked to me about everything. So, that helped. The patience part, I'm not good at that. I've never been a very patient person. So the part talking about now it's done, the retrieval's happened, now you have to wait the 3 months to do the transfer process. It's like, oh, is this ever going to happen? But I guess I was never that worried about it because I didn't have any medical issues behind it other than just my age. So I just kept hoping that, it was going to happen. And I tried to stay positive with the whole thing, and I think that helped.
I think positive attitude does make a difference, and the question is in what way physiologically. I don't have hard evidence on this, but I've always thought that if the patient can be more relaxed, which is hard to do, more relaxed, you have less uterine contractility, and so the receptivity of the endometrium is better. So I try to get them, if you tell someone to relax, they'll be really furious. I mean, it's like telling an insomniac not to think about things and just go to sleep. It's very insulting almost. It shows you don't understand. But what a person can do is focus on relaxing their body muscles. It's kind of like meditation. And then even if they're nervous and their mind is spinning with worry, if they relax their body muscles, which they can do, then the uterine relaxes, and that probably accomplishes a lot.
Okay, let's do 2 more questions. During the transfer for a very nervous patient, do you ever prescribe anything?
Well, classically, people will give the patient Valium to take before the transfer to relax. I don't usually recommend that. It's okay if you want to do that, but I think what's most important is during the transfer, you remember, we got you to relax your body muscles. I'm like a yoga guide, and there's a reason why yoga works, while they're up in that awful position, that embarrassing position, their husband's there, before we do the embryo transfer, I guide them through relaxing from their scalp down to their shoulders, their fingertips, their legs, and down to their toes, and relax their rear end and let it just drop down. And when those muscles relax, then I think that's all you need.
If you get a warm blanket.
And a warm blanket, yes,
it helps.
That's right.
It's a cold room, but they give you a warm blanket. So.
That's really true. And communicating, I like to communicate, and I think communicating with the patient while you're doing it and letting them see it on ultrasound, I think really helps. And if Valium were to really sort of buzz them out, then that might interfere with that communication. But we'll do what they want. I mean, we don't have an objection to it. It just seems to me that that's a kind of a mechanical approach that clinics usually use that don't have good communication with the patient. And so, well, here's your Valium. The doctor ordered this Valium, and we'll wait a half an hour, then come in the room. Okay, get up in stirrups. Okay, we're going to do the transfer now. We don't like to do it that way.
Okay, maybe a good thing would be to go to the site and watch the Today Show live IVF and see kind of what that process was like.
Yeah, that's a good idea. Today Show asked us to do a reality TV, live IVF. We had no idea who the patient was going to be. She agreed to do it, or whether it would be successful or not. It was just absolutely live, so you can really see her emotions and what she went through before and after when we had the pregnancy test. It's all completely unrehearsed, and we just, if it didn't work on her, then that would be okay. We just wanted to tell a true story for the Today Show. So that's on our website if you want to check that out.
Frama would like to know, can a person with heart problems do IVF?
Well, it depends on the heart problem, but it has to be okayed by the cardiologist. But say like it's a Marfan syndrome case, or someone who we really don't want them to get pregnant. It's not a problem getting a gestational surrogate to carry the baby. And you say this was Grandma?
No, her name is Frama.
Oh, I didn't hear it right. But we've had the mother of some patients with different problems carry the babies for their daughter, and it works just fine. So that would be like a 55 or 60-year-old carrying her grandchild. And if she's healthy, it works just fine.
And then the last question is about consultations, and how does that process go?
Well, I think it's important to just find out everything you can. So anybody that would say want to come to our clinic, they have to see us first for a complimentary consultation. We don't charge for that. And it could be 15 minutes or it could be an hour and a half, depending on how complicated their problem. Now, they will have an ultrasound at the hospital. Usually insurance pays for that. And I think an ultrasound is very important, and that's all we really need. Ultrasound plus her history is all we really need to give her the best possible advice. And usually the husband's already had a sperm count, and she may have had a lot of other testing, and if so, we want to get those reports. But the consultation and the office visit, the doctor's office visit, there's no charge associated with that. And if we recommend they do nothing, or they decide this doesn't sound like it's for them, that's just fine. They haven't lost any money in that process. So, is that the last question?
There's a couple about age at 45 or 47. How many embryos would you transfer?
Okay, and with 45-year-old eggs, I would transfer all the embryos we have. 5 embryos, 10 embryos. It sounds like a cowboy, but I'm not a cowboy. There's no chance of a multiple pregnancy at 45 or 47. But we have had pregnancy with women's own eggs at 45, 46, and 47. It's just that it's a much lower pregnancy rate, a dramatically lower pregnancy rate. But it can work with their own eggs in some of the patients.
Okay.
So I'm Dr. Silber. This is Suzanne. And you might say a few closing words, but you can always go to www.infertile.com or call us up and make an appointment. There's no charge for anything. You can see that I'm a pretty old guy, and I'm doing this not for money. I'm doing this because I love it, and it's a mission for me. 314-576-1400, or just check our website out. Suzanne, what do you?
I would just say that, like talking about the consultation, it's pretty much you come in and sit down right here where we are and talk with him, and it's very easy. It's just kind of like this. Sit down and talk about what's going on. What have you been through? What have you already tried? And you go from there. You make the plan, and it's the plan that makes sense for you. Not everybody's the same, and we had the best course of action, and turned out perfect. So I obviously highly recommend it. And the mini IVF definitely worked for me.
Fantastic, and look what we have here. And this is a year ago, huh?
That's a year ago, yes.
Look at those dimples.
It's Alex. Yeah, those dimples.
Alex.
He'll roll his eyes at you if you mention the dimples. But yeah.
Oh, I think this young lad, when he grows up, is going to break some hearts.
Probably.